Welcome to the Abstracts course. I'm Jerry Hoffman. I come from Los Angeles. I've been doing this for quite a while. Many of you I've met in the past. Welcome. How many of you have been to this course before? So there's actually a few people who haven't. Shame on you. Okay, well, we've been doing this for 30-some years, something like that, a long time. And I've gotten to meet a lot of you. And those of you who are new, I hope you'll enjoy this. This should be a really fun course. We have excellent faculty, and let me just say a few things about the course. Go every day in the set schedule. We will run over some lectures, under some lectures, whatever, but we'll always end on time because we suspect that you're really not here just to be in a classroom all day. So we will get you out on time. We promise that. This is a course which is based on that manual. Some of you haven't got the manual. How many don't have the manual yet? I apologize, this is sort of weird. Something happened apparently that it didn't come, but they're working on it. They'll get you them. The manual, you're supposed to read it by tonight, and then there'll be a test in the morning. No, that's not true. There's a lot of data in this manual, and this course is a little different than other courses. It's based on the notion that we should be influenced in what we do by what the literature tells us. And this isn't such a bizarre notion today, but 35 years ago when we first started doing this course, there really was no such notion. And we mostly practiced based on what we learned from our teachers. And the reason we did what they did was because they told us to. And then came along this crazy notion that actually you could study things and figure out a better way to do it, and some of what we did by ourselves wasn't the right thing. And you know this whole story, but in any case, these lectures are based on what's been published in the literature in the last couple of years. Now, those of you who have listened to the abstracts, how many of you listened to the abstracts? Okay, a bunch of you. Know that I spend a lot of my time talking about how just because they wrote it down doesn't mean it's true. So a lot of what's in that manual is not only not better than, but actually worse than our clinical experience. And so we have to run this tightrope. We have to walk this tightrope between understanding that what we think is right just because that's how we've always done it and somebody told us and that's what experience says, and understanding that that can be wrong, it can be misleading, and also understanding that what's published in the literature can be wrong and that experience is tremendously valuable. So I say this all as prologue to remind you that in this room we have more experience about any disease than any of the articles in that manual. We've together actually know a lot about all the things we're talking about. Sometimes it's easy to be misled in our own narrow world because we haven't individually seen all those cases, but together we have a lot of knowledge. And that's why this course is really good if you guys participate. So hopefully it won't just be us standing up here talking to you, but it'll be us having a conversation. Now that can't work 100% of the time, but I really do encourage you to participate, make comments, ask questions, etc. It'll make the course much more fun. How many of you are emergency physicians? How many other physicians, primary care? Great. Any other physicians, surgeons? Okay, I always have to ask that because there are going to be a lot of surgeon jokes and we have to be careful. How about nurse practitioners, PAs? Great, big bunch, great. So anybody I missed? Anybody doing something else? Any gardeners or? Retired, yeah, well. Yeah, I know this guy. Anyway, what else? I guess we'll start. So the first lecture is unlike all the other lectures in the course in that there are no articles. This is a conceptual lecture which I do every couple of years, and it's not the only one in this series, there's a couple, which talk a little bit about how to read a paper. Now at UCLA, where I've been working for the last 35 years, we run a 3-year fellowship on how to be a researcher, how to be a scientist, how to understand research, how to do it well, and therefore how to catch when people do it poorly. Unfortunately, some of you may have heard there's a fellow named John Ioannidis up at Stanford who's got a lot of publicity for writing articles with titles like "Why Most Medical Research Findings Are False." and proving mathematically that the way we do things, most findings are false. They turn out to be wrong. And that shouldn't surprise any of you, right? Because what's in today is always out tomorrow, right? Eggs are good for you. They're terrible for you. They're neutral. You know, it changes all the time, right? So we spend a lot of I'm not going to teach you in the next half hour how to be a methodologist. But I want you to understand that it's really important to be skeptical when you read things, because there are many, many ways in which we can be misled. So I'm just going to go over, this lecture is just a few, and we're just going to touch on a couple of the biggies. As I said, this is part of a series, so these are only 5 today. There's many more that we've done in this series. If you come to the course, we do them periodically. But we're just going to this is just to give you an idea that it's really important to read with a skeptical eye. So let's just go through a couple of them and we'll talk about it. The first one's about a gold standard. What's a gold standard? Let me ask you a different question. Gold standards have to do with testing. How do we know what the truth is when we're looking at a test? Does the test tell us something? Well, what we want to know is compared to what? What's the truth? So the gold standard is the truth. There are 2 things about a test that are important, 2 qualities. What are those 2 qualities? If I want to know, does a white count help me decide whether or not somebody has appendicitis? I got to know 2 things about white count that are really, really important conceptually. Any ideas? I know there's a little read my mind, but think about it. What do I want to know about the test? Is it accurate? So that is, does it tell the truth? So compared to the truth, whatever that is, does the patient have appendicitis? Is the test accurate? And that has 2 components, sensitivity and specificity. What sensitivity? What? False negatives. That's exactly right, but tell me what that means. Because it's actually a little confusing. And we don't want to miss it, right? So how do I test sensitivity? What is sensitivity? Does anybody remember what it is actually? How do I know what that means? You're right, it's about not missing things.
The number of tested positives over the number of true positives.
Right, so in this group on this side has the disease. Sorry guys. You all have it. I want to know, in the people who have it, I do my test, and how often is it positive? Now, how could that have anything to do with not missing it if I'm only doing it in positive people? I'm not looking at negatives, I'm looking at positives. I'm looking at people with the disease. And specificity is in this group. None of you guys are sick, you're lucky. None of you are sick. Specificity is how often will it falsely call it. So sensitivity is only in people with the disease, but we use it in medicine to say, if it's negative, you don't have the disease. How could that be, since we only test sensitivity in the people who have it? And the reason is as follows. Here's the reasoning. If, in fact, in this group who have the disease, there are very few false negatives, if I test my patient and the patient is negative, since there are very few false negatives, it's a really sensitive test, must be a true negative. That's the reasoning. It's not actually true. What we're really doing when we're testing a patient, you and I, is not testing sensitivity, we're testing negative predictive value. What we want to know is, amongst all the people who have a negative test, how many are true negatives and how many are false negatives? They're related, but they're a little different, and they can be very confusing. And I'll get back to this a little bit later when we talk about another pitfall in reading a paper. But I just want you to understand that sensitivity is only tested in people who have the disease. Specificity is only tested in people who don't have the disease. But together, they represent accuracy. Do they tell the truth? There's another, and we'll get back to this concept a little bit later. There's another really important quality of any test that we got to know about. So when I'm reading a research paper, I want to know about sensitivity and specificity. When I'm taking care of a patient, I don't want to do that at all. I only want to know about predictive values. If my patient is positive, are they sick? If they're negative, are they well? And that's a whole different proposition. And those often get confused, and we'll get back to that a little bit later. Okay, but there's something else besides how accurate is it? How well does it predict the truth? Is another quality of tests. What's that other quality? Really important. People don't talk about this a lot. Just think for a second. What else might I want to know about that white count? When I read a white count, what am I reading? It's a number. So that If I read the number, you read the number, we're both going to read the same number. What about if I look at a chest x-ray? Are we both going to read the same number? No, there's something called reliability, or intertest or intratest variability. So I want to know, if I look at the test and you look at the test, will we get the same result? Or if I look at the same test twice, will I always come to the same conclusion? So for a number like a white count, that's pretty straightforward. We know what it means. But for most things in medicines, tests are not so reliable. That is to say, different people looking at the same result may have a very different opinion. Those are two critical characteristics of tests that we'll get back to. Okay, so now let's talk about a gold standard. I want to know if white count really predicts appendicitis. How do I know what is appendicitis? I have a gold standard for the truth. What is appendicitis? So let's forget about appendicitis for a second. What's the gold standard for a heart attack? I want to know whether or not some test predicts heart attacks. What's the gold standard? I have to know who really had it and who didn't, then I see how well the test did. What is the gold standard for a heart attack? How do you know somebody has a heart attack? What? It could be in the cath lab. And what are you looking for in the cath lab? And what do you see in the angio? A blockage. Does a blockage mean a heart attack? Not really. You could have a blockage and not have a heart attack. You could have a heart attack without an obvious blockage. So that's not a really good gold standard. What is the gold standard we use for heart attack? How do we, when we say these people had a heart attack, how do we know? EKG. How good is EKG? Not so good, right? Because you can have a heart attack with ST elevation, without ST elevation. You can have a heart attack with an EKG that looks normal. You can have a really abnormal looking EKG and it's not a heart attack. It's a left bundle branch block. So it's neither sensitive nor specific, okay? And what's more, people read EKGs differently. One guy will say, yeah, that's ST elevation, and the next person will say no. Okay, so this person is speaking some foreign language. I'm going to have to... can you... my Aussie is not very good. Tell me again what you say.
A troponin, I suppose.
Okay, good. So troponins, right? Isn't that how we decide? How good is a troponin? Well, let me ask you this. What was it 20 years ago before we had a troponin? It was a CKMB, and before that it was a CK, and before that it was LDH. Now, how did we change from CKMB to troponin? So what happened was we had this new test. The gold standard was a CKMB. Whenever the troponin and the CKMB disagreed, by definition, the troponin was wrong because the gold standard was the CKMB. So when they disagreed, the troponin was wrong. And then somebody decided, you know what? The people where they disagree, the troponin predicts whether or not they die and predicts the angio a little bit better than the MB. So let's switch the gold standard. And now we'll say every time they disagree, the MB is wrong. But we just made that up. So we used another gold standard, which is outcome. How did they sort of look? But that's not gold. Where is there a really good gold standard? Let's talk about pulmonary embolism. What's the gold standard for pulmonary embolism? What's the gold standard? So what do we use as a gold standard? I mean, we use a CT pulmonary angiogram, right? But we're trying to test, is it any good? So we have to have a gold standard that we compare it to. What's the gold standard we use? Standard angiogram, right? And how good is standard angiogram? Well, it's not very good. Compared to what? What's the real gold standard? Autopsy. But autopsy is not that good a gold standard for a lot of reasons, right? One is it's really hard to do on your patient. You know, sorry, sir, we're going to have to do an autopsy on you to find out whether or not you're sick. So it's not really terribly convenient, but in addition, is it really a gold standard? So we know, for example, that when people die, they sometimes form perimortem clots. So there'll be false positives on the autopsy. And we also know that sometimes people break up clots at the time of death. So there'll be negatives, false negatives on an autopsy. And we also know that if we want to use it for clinical medicine, let's say we want to say, how often are you likely to be tachycardic when you have a PE? If we use a a gold standard of a PE that killed you, that might be very different than a PE that doesn't kill you. So if the gold standard was only those that were big enough to kill you, we might find a lot of tachycardia, and in real normal PEs, there might be no tachycardia. So it's a clinically irrelevant gold standard for most patients. And then finally, what's the last thing I said was the second characteristic of a test you need to know? How reliable is an autopsy? Any of you read any autopsy reports from time to time? What's the most common cause of death in formal autopsy reports? Cardiac arrest. What does that mean? That means they couldn't find the cause of death. The cause of death is he's dead. And what's more, it's not only that they can't find it often, but they disagree with each other. You give two pathologists the same autopsy, they find different things. You slice it differently, the sections, and you find different things. You give the same pathologist, has been studied, the same slides, and they often come up with different answers. It's not a reliable test. Why am I telling you all of this? Because every time you read a paper which says, we showed blah, 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 you have to ask yourself, what was the gold standard? Now, there is no gold standard. There's no such thing. So what we have to do then is say, do I trust this gold standard? Does it make sense? Is it reasonable? Do I think it's probably pretty close? CKMB is probably pretty close to heart attack. CKMB plus EKG, maybe that's useful. A smart person looking at them, we had two cardiologists decide, based on all the information, that's probably right most of the time. But a lot of times the gold standard isn't gold at all. And in fact, if you read many papers, a lot of times the test that's being used is its own gold standard. Anytime you see a study which says it was 100% sensitive and specific, which means it was perfect, means they believed it whenever it was true, whatever it said, they believed it. And you see lots of these studies. Or it was 100% sensitive but 98% specific, means they mostly believed it unless something proved they were wrong. And that's with CT studies all the time, where it's very sensitive and specific because basically that was the basis for the clinical diagnosis. They believed the CT. Or maybe they didn't always believe the CT, but they only got the definitive test if the CT was abnormal. So in the studies of subarachnoid hemorrhage, for example, the famous study which says you can believe the CT was the only test they did in 60% of the patients. So most of the time, they just assumed it was right. And then they said, look at that, it's really good. That didn't mean it was any good. So, again, I promise you, every of the things we're going to talk about today, if you go back to take out the New England Journal, the JAMA, BMJ, any journal, including Annals of Emergency Medicine, which is in many ways a very good journal, and if you go look at their studies, not just about gold standards, but about all the things we're going to talk about and many others that we've talked about over the years, you will find multiple examples of, wait a second, that's not true. There was no gold standard here. Or I don't trust this gold. It was what somebody thought. How do we know that BNP is good for heart failure? What was the gold standard in all those studies? This is a good one. It was what two cardiologists thought when they looked at all the data. That may seem really pretty reasonable. Two cardiologists got to look at the whole chart, and then they decided whether it was good or not. Now, part of the problem is they knew what the BNP was when they were deciding. So that's bad, because that could influence them, right? But here's a bigger problem, and this is sort of fascinating. Why do we want to have a BNP to know whether or not it's heart failure? Somebody's dyspneic, we want to know it's heart failure. We get a BNP because we're not good enough. Because when we decide clinically, we disagree with each other 20% of the time. And we disagree with the cardiologist who gets to look at the whole chart 20% of the time. That means we're wrong 20% of the time, right? Well, it doesn't mean that. Maybe we're right and they're wrong. Okay, but let's assume it means we're wrong 20% of the time. So instead, they get two cardiologists to review the chart, and then BNP was really good or was moderately good. But then it turns out there are two studies which took two different cardiologists and had them review all the data and compared them to each other. And how often did they disagree with each other? 20% of the time. The whole thing is a pack of cards. It's not true. It's a complete silliness. So when you go read a paper, understand that when you're looking at a test, it's only as good as the gold standard, and the gold standard often is not very good. And you can tell when it's not very good. Okay, next thing, and because I don't have time, I'm not going to get through all of these. I may get through 2 out of the 4 or 5, but that's okay. You can read these on your own time. Sensitivity and negative predictive value. I already told you that sensitivity is only to people with disease. Okay, so if 100 people on this side of the room and the test finds the disease in 98 of them, that's called 98% sensitive. And that's really good. It means very few false negatives. If I do it in my patient, I get a negative, I know this test is rarely false negative. When somebody's got the disease, I may say, it's a pretty good test, right? They probably don't have it. But I'm actually answering a different question. I'm looking at the negative predictive value. Now, negative predictive value is something you'll read in papers all the time. And it can look really good because the test is very sensitive. There are very few false negatives, therefore it's pretty good. Or it can be, even though the test is lousy, the negative predictive value is really good. And that's often the case, but authors like to hide that from us. So I'm going to give you an example. If in this room, I wanted to know how many of you are suffering a heart attack right now. And my test was I flip a coin, and if it's tails, you don't have a heart attack. Every time I got a tail, would I be right? The negative predictive value would be 100%. Even though the test, we would imagine, would only be 50% sensitive. If I looked at it in a whole bunch of people with a heart attack, it would be wrong half the time, right? I mean, we would guess, right? So how does it have a negative predictive value of 100% in this room? Because the negative predictive value before I did the test was 100%, because none of you are having a heart attack. If you do a test in a low prevalence population, no matter how lousy the test is, when it's negative, it's almost always right, because nobody's sick. There's a famous paper that we're going to review in the editor's choice about CT coronary angiogram. It was really, really great, because when it was negative, in 1,000 patients who were sent to the OBS unit for low-risk MI, when it was negative, it only missed 1. It was more than 99% negative predictive value. But more than 99% of the patients didn't have anything, which meant that it had nothing to do with the test. It had to do with the fact that when you send somebody to the OBS ward, it means you only do it because you know they're not sick. In fact, the really good test is, did you decide to admit them to the hospital or just send them to the OBS ward? Because you're really good. That's a really good test. When you decide to send them to the OBS ward, it means they're not sick. Is that true? Of course it's true. And they touted that as the negative predictive value was really great. It had nothing to do with the negative, with the test. So you need to look at that. And negative predictive value, by the way, in a low prevalence group is always better than sensitivity. And sometimes a sensitive test helps you, but in many cases it has nothing to do with the test. So be aware of that. Same is true with positive predictive value in a high prevalence thing, but that's much less of a problem. But I promise you, get the animals and look, and there'll be a whole bunch of studies every month or two touting how good a test is because it had a high negative predictive value. And that's irrelevant. You don't want that from a researcher. That's what you do in practice. You don't care about sensitivity in practice. You care about negative predictive value. When this patient is negative, can I trust the test? But that's based on, was it a good test? And the way a researcher finds that out has nothing to do with negative predictive value. It only has to do with sensitivity and specificity. Don't confuse the two. When you do it at your own peril. And we're misled all the time by this. Let's see, there are a couple of others that we can spend 5 minutes on. Distinguish between significant and important. Beware. So let's do significant and important. What does significant mean in English? When I say that's a significant finding, what do I mean? I mean, it's important, right? That's what the word means. In medicine, there are a lot of words that don't mean what they mean in English. Sensitivity does mean the same thing. If you say that dog that's sniffing for drugs has a sensitive nose, what does that mean? It means if there are drugs there, it will find it. That's the definition of sensitivity in medicine. If you say specifically, what I specifically mean in English, it doesn't mean specificity in medicine. Specificity in medicine means in the people who don't have the disease, there won't be false positives. But in English, when I say, I specifically mean, I'm talking about positive predictive value. I mean, if it's positive, if I say X, it means Y. So there's a lot of things in medicine where the language we use is very different than what it is in common parlance. Bias in a study doesn't mean what we mean by bias when we're talking about just a biased person. It means something a little different. So one of the biggest examples of this, and the worst one for anybody who's trying to understand medical research, is the word statistically significant. So significant in English means important. What does it mean in statistics? What does it mean? Anybody? Not likely to be due to chance alone. Now, I said a few things that are important there. I said not likely. Doesn't mean it isn't due to chance alone. It's just unlikely to be due to chance alone. And the way we define that is p-value of less than 0.05 means there's less than a 5% chance that it would occur just by chance alone. And to be more precise, it means if I'm testing two things against each other, if they're significantly different, it means that I would be unlikely to find this big a difference that we found in this population, the size of it that we tested, if the two things I'm testing were identical. If they're exactly the same, we wouldn't find that big of a difference. You test two coins, you flip them, you expect to find a little difference, right, if you're flipping for heads and tails, but you don't expect to find a huge difference if they're really the same coins. Okay? In the world of medicine, how many things are identical? There's nothing that's identical. No two drugs are identical. Nothing is the same as placebo. So you would expect to find some difference. And one of the ironies, if you do a big enough sample, you will always find a statistically significant difference because they're not identical. So you would expect to find some trivial difference. But there is nothing in the word statistically significant that remotely implies important. It just means they're probably not identical. They may be different in the most marginal way. It doesn't matter. All I care is they're not exactly the same. And even that is not entirely true. They might be the same. This just might be by random chance. How often do weird things happen by chance? How often have you had an experience where you say, I just thought of you yesterday and then you called today? How many people have you thought of in the last 12 years? And how many of them called the next day? Not too many, but once in a while it happens. So I'm going to give you a really good example of probability and weird things, okay? When your parents met, they had to like each other, right? And then they had to get together, and then they had to have sex, and then they had to be one egg and one sperm out of all the many possibilities. Statistically, the chance that it would be you is very, very small. More likely it would have been some different egg and some different sperm. Now let's go back 500 years. Do you know how many of those minuscule possibilities had to be exactly right between your great-great-great-great-grandparent and great-great-great? They had to meet, they had to be in the same community, they had to be in the same migration, because most of them over 500 years, they moved villages. They had to not be killed in the war, and there were lots of wars and killings. They had to not die in childbirth, not just one, but 100 of them. And each one had to have the exact right sperm and exact right egg out of thousands of sperms and eggs. What's the chance that you would be here today? Zero. It's zero. Probabilistically, it approaches zero. What's the chance that somebody would be here today? One. Somebody was the egg and sperm. It just happened to be us. Weird things happen all the time. And I can prove to you mathematically that when you say p-values, particularly when you're comparing more than two things, it's meaningless. So it's bad enough this type of statistics, called frequent statistics, doesn't tell us any of the things that we really want to know about disease, and we really should get rid of it from all of our publications. But what makes it worse is that word significant. Because when you read in the New York Times it was significantly different, most people think it mattered. And almost all of what we study in medicine doesn't matter. That's sort of weird to say that. It's the last thing I'm going to say. But think about it. There are two reasons you can get a statistically significant result. One is there's a trivial difference and you have enough people to find it, or just by chance. That also happens. And the other is a big difference. Big difference is we almost never need to study. They're obvious. Nobody ever did a study to see whether or not antibiotics work for pneumonia. There is no such study. We all know they work for pneumonia. We only test things where at best the difference is very marginal. Is clopidogrel adding it to aspirin better? Well, you got to do thousands of patients to find a trivial difference. It's never clinically significant, or we wouldn't be testing it. So when you read the word significant, always go, they're lying to me.